welcome to the Effective Community-Based CCC Interventions Roundtable. Like I said, we have a great presentation for everyone today, so we'll get to it very shortly. Just a quick reminder, as Hugh mentioned in the plenary, we have interpretation, so please do select this in the language you're most comfortable with. You should see that just down at the bottom of your screen. I'm very pleased to introduce our co-hosts, our co-chairs, excuse me, Professor Suraj Subramanian and Dr. David Gillette. And I'm happy to introduce myself as the host for this roundtable as well. My name is Danica.
Thanks very much, Danica. Can everybody hear me?
Yes.
Yep. My name's David Gillette. I'm a
Yes.
plastic surgeon, and I live in Perth in Western Australia. And when I was asked to be involved in this group, it was very interesting to me because Western Australia is a very big state. It's about 2.5 million square kilometres, so it's the size of Western Europe. But we've only got 3 million people. So there's a lot for our patients. A lot of them travel very long distances, sometimes up to 6,000 kilometres for a return trip to the hospital. So how to provide best care to these patients without burdening them with a huge amount of travel is very important to me. Could we have the next slide, please? Danica, would you mind? Thank you. I'd like firstly to introduce the rest of this group. And it's been a great privilege to me to work with such enthusiastic and interested specialists from all over the world. Marina Campodonica, she's a pediatric dentist, and she's from Chile. Getor is a cleft surgeon from Ethiopia. Christelle is an anaesthetist, and she's from Madagascar. Savitha is a speech pathologist from Chennai in India. Pumulo is a pediatrician from Zambia. And Felicity is a cleft surgeon from Edinburgh in the United Kingdom. Andrea is an orthodontist from Mexico, and Fanawam is a social worker from northeast Thailand. So it was a great group with a big spread of specialties and also geography. And that just outlines where the people were from. If we could have the next slide, please. As Hugh said, we followed a sprint process, and there were basically, this is the third phase. So the first phase, or the foundations phase, was basically preparation. The second phase, and if we could go to the next slide now, please, consisted of 4 separate group meetings. Each meeting went for 75 minutes. And for me, they were late in the evening, but for different people, they were various times through the day. And we met and we went through a process of exploring, surveying, analysing, and then we came up with some recommendations, which we'll be presenting tonight. Next slide, please. So our first meeting was the exploring meeting. And this meeting, we spent the 75 minutes, first of all, introducing ourselves to everybody else and just getting to know each other. And we talked about what are some of the issues that are difficult for the families and the children who live a long way away from the centralised cleft centre. And we talked about what people have done in different settings to help to minimise the burden of care for these children. And some of that was things like assisting with transport, assisting with accommodation, the use of telehealth to minimise the requirements, good coordination so that when a child does come to the central hospital, we could get lots and lots of things done on the one visit to avoid unnecessary travel. And this just sort of points some of the points that we discussed on that first meeting. If we could have the next slide, please. After that meeting, we then met again, and we'd had the initial discussion, and we met and we discussed what do we want to know? What further questions have we got that we would like to survey a larger group of cleft professionals from around the world? And we came up with 16 questions. And the process wasn't easy, and we used quite a lot of open-ended questions, although they were a little bit more difficult to analyze because the options were so varied, we couldn't put everything down into a yes, no, or a 50 versus 100 answer. So a lot of the questions were open-ended, which did require a qualitative analysis of some of the questions. Once we agreed on the questions, they were posted online in English, French, and Spanish, and then they were shared across cleft professionals. But people only had a week to answer, so it was a fairly short time. We, however, were very lucky. We got a good response rate for that. If we could have the next one. Our third meeting was analysing the responses. So as I said, we had 100 responses from 31 countries. Interestingly, 18 of them were from high-income countries, and the majority, 82 of the responses that we received were from low and middle-income countries. Some of the questions were able to be analysed in a quantitative fashion, but for a lot of them, there was the need for a thematic analysis or a qualitative method approach to look at the answers to the questions. Next slide, please. And I'm going through this fairly quickly because I think the really important thing tonight is the roundtable discussion, and I want to make sure that we've got plenty of time for that. When it came to the analysis, we had, as you can see, a very wide spread of cleft professionals. The speech pathologists came out number one in numbers, and surgeons came out number two. The next question, please. Then the other thing that we found is that there's a good spread of experience, some fairly junior and enthusiastic cleft professionals from 1 to 5 years, and an equally large group of very experienced cleft professionals who've been involved in this area for 16 or more years. Next slide, please. So we came up, as I said, with 16 questions. They were then formatted in an appropriate way, and then we put them on the internet. And there was a survey monkey, and everybody answered that. And we then came to our next meeting, if we could have the next slide, where we came up with recommendations. So we went through the answers to the questions, and we came up with 5 key recommendations. And Suraj is going to go into the details of these recommendations, but I'll quickly mention what we came up with. Our first recommendation was that in order to reduce the burden of care for the children who live remote from the cleft centre, we should be integrating the cleft care into existing community health programs. So we don't want to necessarily be reinventing the wheel. We want to use services that are already available. This recommendation 2 was that we should establish comprehensive financial and logistical support for the program. So we felt that by getting the necessary financing established early on and the necessary structure to coordinate the program, we would be much more likely to be successful. Recommendation was implementing what we've called a hybrid care model or models. And by this, we mean a hybrid of face-to-face meetings and where possible using telehealth or other technology apps to enable the cleft professionals to interact with the patients and with their families. The fourth recommendation was the development and implementation of the comprehensive caregiver training and support programs. And we had different groups around the world that used different techniques for this, and we looked at using community health workers, the community nurses, local doctors, even the cleft patients themselves, the older patients, the parents and families, the cleft support groups. But it was important that all of the people involved are comprehensively trained so that they know about the cleft care and they interact with the central team, and they need to be trained and they also need to be supported by the team. The last recommendation was, although it's a great thing to reduce burden of care for our patients, and this is certainly something that everybody in the group, we're all very keen to do, one of the things we felt that we had to be careful of is that we weren't reducing the burden of care, but also reducing the quality of the care. So we need to be aware of the final outcomes. And when a program such as this is established, it's important that they're set up early on. There are monitoring processes and outcome indicators that can be used to be certain that the program is working, that we are in fact reducing the burden of care without compromising the quality of care and the final outcomes. Suraj is now Suraj is my co-chair, and Suraj is known to a lot of you, is a professor of speech pathology from Chennai, and Suraj is going to go through the recommendations in more detail, and I'll hand it over to Suraj now.
Yep. Thank you so much, Dr. David. Can you all hear me? Yeah, thank you. So let me start. Before I start, I want to share something with the participants who are here. There are some information which I'm going to share with you all may resonate with you, the kind of thing which I'm talking may resonate. So keep those, if you have some interesting questions or interesting comments to share, please note it down so that we can have a good discussion during the time. So as we go into each recommendation, I will touch upon the important elements we learned from this. How did we get into this recommendation? Dr. David has beautifully explained, but I will take a minute to explain that. So we had a set of questions which are open-ended and then, in yes/no questions. These open-ended questions opened the doors for us to get the detail which we wanted to present. And the question which we have, how could we take services closer to the community cannot be answered in yes, no, or not applicable. We need information from people to understand so that we can analyze. And we were happy that we were able to get some very good information for us to share with you all and then also learn from your experience during the roundtable. Tanaka, can we go to the next slide, please? So let me go to the first recommendation. Integrating cleft care into existing community health programs. It is so easy that, like what Dr. David said, we don't have to do something new. How can we make it usable with the systems which are already available in the community? And this is something which was felt by most of the participants who participated in the survey. And what did they mean by integrating cleft care? That means we can bring services closer to their residences. And to do that, there needs a network to make sure that we engage with local service partners. It could be NGOs, government organizations, and all of that. And by doing that, automatically we could decrease the need for long distance travel. So we identified to do this, a team should invest a lot of time in developing a comprehensive care pathway. How can we start a comprehensive pathway? Where to start, whom to connect, how to proceed, and what are all the partnership which a team should develop to engage, implement, and provide care. And I'm going to touch upon two of the important rationales from which we identified that this is one of the important recommendations which we should share, which is about enhancing accessibility and improving the continuity of care. Danaka, next slide, please. Okay, so I'm going to touch upon these based on this accessibility, community, and how beneficial it is. all this information were taken from the survey response, and then I'm going to extract that information and share it with you all. Dhanaka, next slide. So what did we hear from participants who were? And from what Dr. David said, most of the participants who participated were from LMIC region. They were very much aware of what is happening there, and they were very much aware of the challenges which patients, families, and service providers face. And we could see that most of them travel more than 3 hours of time one way to reach the tertiary care hospital. By this means, we understand that accessibility is one of the key factor which has to be addressed first. So to address that, we need to integrate the plan which is closer to the community. Next. What could be, next slide, please, Danaka. So what could we move to the community? And we were so surprised to see that we had all options listed by professionals. That means over time, teams have equipped themselves to go and provide services at the community. I'm not going to point out which numbers stood out most or which numbers stood out less, but I want to see the fact that all services, and there are efforts taken by service providers in different parts of the country to see how can they take it. And what stood out most was procedures which doesn't need extensive care, procedures which doesn't need admission, hospitalization, are almost ready to be provided at the community level. And we also see some elements like speech therapy, dental, orthodontic adjustment. These are emerging much more faster because the tele model has supported to provide these services closer to home. And I think the readiness for all these programs indicates that there are many part of cleft care services can be taken closer to the community and are ready to be implemented at the community level itself. Next slide, please. And the next question which we ask the community is, would this be beneficial if a team plans on moving a cleft care services closer to the community? Would that be beneficial? Most of them said it would be extremely beneficial for families. But I'm not going to focus on that because we are trying to recommend what works. I'm going to focus on the next question. How feasible do you believe to take CCC service closer to the community? Again, here, I want to focus on the questions which says not at all feasible, slightly feasible, moderately feasible, because that's the important aspect of developing a comprehensive care or a project. So to do a feasibility study and check whether the demographics, geopolitical situation, and the terrain allows you to provide such a care or not. And understanding a model is the key word which I would like to emphasize here. To before implementation and intent of implementation, to do a feasibility study is very important. So with that, I close the first part of the recommendation where integrating cleft care services closer to the community is very important. Use available resources at the community and see how best we could engage. The next slide, please, Janaka. Most important element, you have an idea, you want to implement. Then we asked, if you want to implement, what are all the things which you require? And immediately the first question answer which we heard was, we need sustainable funding. And that's something which came across as a most important point. And promote equitable access to care. If there are families coming from different places, do all need to get same amount of benefits? How can we leverage benefits within the community who are availing services depending upon independent challenges? That is something which we came across as some of the important points. To do this, what the recommendation which we think was, we have to diversify funding sources. Think of public-private partnership models within your society locality to see how best we can implement and what are all the services which can come in a non-monetary way and how it can be fed in the community. And that will help us to identify, sustainable funding models. When we have a sustainable models, continuity of care can be provided. In this context, I want to explain on the two aspects, sustainability and promoting equitable access from the responses which we had. Tanaka, next slide, please. So when we asked about what are the important elements which are required to support care, naturally, financial resources came as the most important aspect. And after financial resources, trained personal workers, so that they want dedicated workers to be trained and implemented. And to provide or implement care or to reach the last mile, there is a need for transportation and equipment. I understand equipment has come out because there are many services are taken to the community. So for example, to do a nutrition or assessment to weight, there may be basic equipments required. There are dental monitoring apps are used in different communities. It requires basic equipment. So these are the basic elements which which are important elements to be required to implement a project. The next question which asks, what are the important, next slide please, Danaka. Is there something which will have a concern that, such a model can have a challenge? Naturally, we all know that not all patients stay in the same community or stay in a, some small radius kilometer or something like that. So they live in a very, staggered. So it is very difficult to identify one common place and set up a hub there, satellite center or providing care. So to be able to identify services, identify a place to provide services is an important factor for a successful implementation of the program. And even if you take it closer to their homes, acceptance from the families is identified as one of the important factors to be able to receive care closer to their homes. And the next challenging with the growing cleft care services, there are multiple service providers providing care within the same region. If that is the case, how could we set up a care in a small environment is a question which came up as an important point, which will determine providing continuous care. And then operational cost. Cleft is not a condition where in a community more people need intervention. It's a very small group. If it is such a case, what is the requirement for setting up an infrastructure and recurring expenses? This is where idea comes, where we need to integrate to the existing program so that infrastructure costs, human resources costs could be shared and utilized. Moving on to the next recommendation. Next slide, please, Danaka. Implementing hybrid care models. Initially, our focus was thinking we should implement tele models, but the response which we got was interesting, and we moved to name this as implement hybrid care because we all know that this is an integral part for community outreach, which could overcome the access barriers and could evolve as a sustainable model. And to do this, we need to have a hybrid model framework. How this hybrid model will work. When will a patient move from a tele to an in-person and in-person back to a tele? That framework is important to set up. And this is for all, professional, who are providing care. And how could we integrate this kind of model in the community was very important. We have some examples to share to see how, in different parts of the world, how they have implemented. But I would like to stress on the hybrid model of care and the reason why we chose that. Next slide, please. This response was very interesting for us. We did not have a runaway success for tele rehab. There are many people said, yes, they use tele. There are many centers who said, we do not use tele. There are many responses who said in a limited way. So it is a natural organic thing which came up to us that it has to be hybrid because the geography of the place determines and the socio-economic status of the family and the penetration of internet and technology is very important to identify. So teletechnology is not something is generic for all. A team who is interested in working it, when they do the needs assessment or a feasibility assessment, they will have to understand how much of care can be moved to tele and what is the framework in which this can be operated. Without a framework, implementing such a method may not be a success story. And let's move on to see the different examples which we got. We got an example from Zambia, where the nutrition monitoring is happening at the pre-operative stage level. And this is a simple technology using WhatsApp. WhatsApp has been used as a communication option where the treating team gets in touch with the local team, and they also had a WhatsApp group where the families were able to communicate, and they were informed about what are all the measurements which they have to take. And this naturally reduces one travel time or some other decision which needs to be made at the community level. And a psychosocial support effort, which is taken in Thailand as a part of the NWDF project. And you can see that, there is a way that services can be provided close at home, and psychosocial is a new element of care, which is evolving across many teams and across countries. So it shows that, this is an interesting element which doesn't need in-person visit, which can be provided. And it's so interesting that when you have a group of children working together, it's an activity which will motivate children to come back, learn, and take some good information. And then in the same project, we also heard some interesting element of hybrid care, where patients already in implemented hybrid care, where patients take in-person assessment, also come for tele sessions and receive speech therapy. Next one, please. Next slide, please. Yeah. So we saw an example of nutrition. We saw an example of psychosocial support. We saw an example of tele. Now moving into the dental. So there exists a model where patients can scan a QR code and get some information about dental. They can scan and send their photos of dental images, and then those images are screened by the specialist team. Again, this reduces a lot of travel time and effort from the family side, and see how tele project can support dental care. And in Perth, a telehealth and dental monitoring system which is already in place to support families coming from longer distance in providing reducing the burden of traveling to a tertiary care center and then receiving access. So by this, we got to know that implementation of a hybrid model of care is more important, more effective, and could be more a sustainable option. Next slide, please. This is something very important. Training and support programs. This is something which we have heard a lot. If we have to develop a community-based program, human resources are important, and the human resources providing care is the more key element in the success of a community-based program. So how could we train them to go to the next level of providing care? So a model which is developed have to address on developing a training program to support the community workers or the grassroots level workers, focusing on empowering families, and then also identify a feedback mechanism to get information about the services which they have received. I'm going to the next most important recommendation 5, establishing monitoring and evaluation indicators. We all know that to achieve this, all programs should have a metric like this. To do this, there is a need for assessment protocols, there is a need for a data management system, and there is a need for program evaluation. And this is very important for evaluating progress and establishing accountability. I want to focus on some key elements which we heard from respondents here. Next slide, please. We all know that when we look at evaluating indicators or monitoring indicators, clinical functional outcomes and accessibility and patients and families' overall well-being are commonly taken. But I would like to touch upon 3 points which we heard from the respondent. We felt it's unique and important to address in a forum where people are trying to implement. I'm going to focus on 3 elements. 1, communication, access, and patient involvement. Can we go to the next slide, please? Enhancing communication. What we heard from a respondent, there should be an open dialogue, promote open communication channels, provide consistent support, and ensure access to treatment and resources. And this is very important when we are trying to move services from a tertiary care hospital to a community setting, because buy-in model from the patients and families are very, very important. Only when a communication is provided to them properly, follow-up to the camps at the communities are very important. And the next most important aspect is shared decision making. when the decision is made about a treatment, we should be able to identify, the patient's preference and, the family input, and the treatment plan should be based on this. Just because a care is provided closer to their homes, it cannot be so that a team can make a decision on their own. This is very important on other aspects also. When we make a shared decision making, we also take into account that what are the financial resources which are required, what are all the, how can we best manage time to providing care for children, and how many, there are many centers where, they need to identify how many professionals can they take for a community visit. So to make sure that the team is well planned, the shared decision making is very important, because most of the time we have heard from patients that follow up for even community programs are not there. It could be a possibility that there is a gap, that this decision making process is not significantly given much importance. Next slide, please. Optimizing treatment. For somebody to keep coming back to a treatment, and especially when it is provided away from a setup where there is a lot of financial and efforts are placed, getting the treatment right at the first time is very important. And how could we minimize the need for repeated procedures? These two are very important in seeing a very good response or some kind of compliance from patient. And if we are able to do that, and we will know that how good the response from the families are. And resource allocation, how much financial aid, transportation, affordable care, these all come under the umbrella of cost analysis, to see whether the amount of money which we are investing is producing the result or not. So these all factors have to be kept in mind when we are trying to implement such a project. So these are the key points from, in this particular recommendation which came across in our responses. I think a treating team or a team which is interested in setting up a model have to put all these factors in the planning stage itself, so that they can come up with a model which could be more sustainable, more efficient. Next slide, please. What comes in all these recommendation is task shifting. When we implement something at the community, we all know that it is not given by the primary providers, where we may have extra hands, which may be non-professionals or professionals at different levels who are working in the community, who may not be directly cleft care providers. So this comes in all parts of, recommendation which we have made. And I do not have to explain to this group about the benefits of task shifting and challenges, but I would like to highlight what we heard from the responses. I would like to read that. Task shifting is seen as a viable strategy, but it requires careful planning, training, and supervision. A clear outline of the scope of practice and ethical consideration is essential. And the most important, the correct task to be shifted is a key element. I think these 3 points summarizes the idea of how a team should have a keen eye on this particular factor of task shifting. Next slide, please. As we have touched upon most of the recommendations which came up from the the responses which we have got, I would like to present this for your reading. When we asked 2 questions about what does the burden of care for patients and their family mean to you, we had a response which focuses on economic resources, patient care, and then the social or cultural impact or the family which go through. I think these are important elements which is well understood, but I would like to focus on the point, what are all the factors which they think will reduce the burden of care. I think clustering healthcare appointments, even if you are doing a community project, please try to keep in mind how can you cluster multiple appointments at the same time. And then I don't think I would like to restrict to surgery alone as one aspect. I would like to extend it to multiple beyond surgery. It could be dental, it could be speech. Anything we need to start in the most ideal way, so that we optimize treatment or use the resources effectively and the patient gets the best benefit. And most importantly, sometimes we take it for granted that this is the level of information parents should receive or the community should receive. I think there is an emphasis that precise information regarding the treatment needs to be given, and they also need to be given an action plan. Sometimes the background, takes the professional or the team, chance that this is the information which they can comprehend or they can receive. I think there should be a lot of focus on what is the exact information and what is the expected response from the caregiver or the community has to be stressed. With this, I would like to summarize, and I'm sure you will have multiple questions to ask for our in the roundtable discussion. I will hand this session over to Marina, who will run the roundtable session for us. Thank you all.
Thank you, Suraj, and also thank you to Dr. David for your clear presentation about all the work the group did. And so I would like to invite all the participants to participate of the roundtable. We pointed out some questions, so we would like to first, if someone has to give a comment, we would like to hear them. And then we have some questions we will ask, and we hope you can give your opinions and how in your different settings all these points are treated, or if you have some issues with them, or what are your most greatest challenges in this topic. So we are open to listen to you and to see if someone has to say. It would be great to hear to you. Please.
Yeah, hi.
Yeah.
I'm Fernando. I'm a speech pathologist from the Philippines. One of the things that we do here in my country when we try to develop community-based healthcare is to coordinate with the local government units in the small towns, etc. Why? Because number one, some of these government units have all right, wait a minute. It says switch to English. All right, some of these government units have health sector units, and they're able to provide additional manpower as well as resources. And so when we do connect with the local government, the government officials also provide the support that we need to pursue our community-based health programs. And this would definitely work with community-based cleft care. So that's one thing that I would probably want to share with everybody, that if you plan to proceed with a community-based cleft care program, it will help to connect with or coordinate with the local government units in those small towns. Thank you.
Thank you very much for your opinion. Someone else? Danielle, maybe you have some opinion? Dr. Summerland, please.
I have one, but later.
I'd just like to comment on that. I was going to ask the same question, actually. How much can you expect? I'd like to ask Suraj, actually, in your what you've done in Chennai, how much has government, national or local government been involved? And is it possible to really ask everybody, is it possible to do this without some sort of government official involvement?
Thank you, Dr. Somalad. I think Professor Rupa is also here. So we work with different agencies in the government. We work with school system. We work with the grassroots level system. So when we work with them, we get human resources, we get infrastructure, which we do not have to spend any money on. and then we have a monitoring system which will be developed. So the only effort which we will have to, the treating team will have to take is take the professionals there and the instruments. So we automatically reduce the cost of overheads of electricity bill, setting up an infrastructure, other work related to that. And there is also opportunity that when we work with government, you have more than one satellite center. You are not dependent on one place. You can move to one place to another place and use the available resources there. So I think working with them makes lot of non-monetary contribution.
Great. Thank you, Suraj. Felicity, please.
Hi, everyone. Question really for everyone, but particularly Fernando. It follows on from the point you made and that Brian made. Philippines is great because you have such challenging geography, and particularly for maternal and child health, you've got an amazing setup. But we're looking at this in this room from a cleft perspective. And if every specialist group went to all the local community centers and said, this is what you need to do to get task shift care for our patients with cleft. Someone else says it for cancer. How do we manage that in a practical way without the community health center saying, oh, not another one. I just heard from the cancer people and now here are the cleft people. So any strategies for integrating in a least burdensome way, but also any strategies for making sure clefts doesn't get forgotten? It's a tricky balance.
Okay, Fernando, please.
Yes, if I may. One of the things that might help a cleft group, cleft care group entering in a community is to first identify what are the health priorities of the community. There will always be a sector there on child care, child health. And that would be, and if there is such, if those sectors are present, then that would, lead the way for cleft care to be part of that. And then that becomes an integrated agenda of the local community. So, things like that would help because it's going to be part of their program on child health care. I hope that answers your question, or, that helps. Before we move on, one of the things I'd like to add on to what Suraj answered a while ago about support from the local government. Sometimes there are social civic groups in small communities. They can also be tapped to, support these projects. And a lot of these social civic groups have connections with private industries, private companies who can provide either financial support or logistical support to the cleft project. So those are the entities, those are the people that can be tapped in a community if we want to get the community-based cleft care going as well. Thanks.
Thank you.
Okay, thank you. Dr. Yuri, you are waiting patiently. Thank you very much.
Thank you. I just want to say that the idea of burden of care was mentioned even in the Euroclad project as an important part of the quality of the treatment. So this stayed with me as a major question, how to measure first choosing the best protocol with less burden of care, and also to measure the burden of care of my own activity. How many surgeries, how many visits. So if we can include this criteria, burden of care, in the good practice, it should be also a part of the good practice in all the studies. Probably this parameter, burden of care, should be taken more seriously as a measure of good practice. This is all what I'd like to say.
Thank you. Julieta. Please, if someone wants to talk, you can raise your hand so I can follow some order, please. Thank you.
Julieta, you're mute.
You are on mute, Julieta. You have to unmute your...
Julieta, tu micrófono está apagado. Perdón.
Oye, ok. Buen día a todos. Soy
Buen
Julieta
día.
de la Fundación Ainina Cuna de Cochabamba, Bolivia. Me gustaría compartir un poco sobre la experiencia de la Fundación en cuanto a alianzas estratégicas con instituciones cuando se trata de abordar la temática de la fisura, porque es un tema bastante largo, no es tan inmediato como una rehabilitación cuando se habla de una rehabilitación seria, ¿no? Desde el abordaje de la familia. Entonces, lo que a nosotros nos ha funcionado bien es hacer alianzas estratégicas con gobiernos municipales locales, empresas privadas, toda institución que quiera, que requiera participar de forma activa, como incluso instituciones que no tienen que ver con el tema salud, porque una realidad de nuestro país es que no podemos depender de la cooperación internacional permanentemente por la elevada incidencia de casos que hay en Bolivia, que es una de las más altas a nivel latinoamericano. Entonces, esto es sumamente importante, establecer estos acuerdos con toda institución que quiere aportar a la rehabilitación. Y este modelo híbrido, por ejemplo, que nos había comentado el doctor, funcionó desde la época de la pandemia acá en Bolivia, en Itacuna, y es sumamente efectivo por las distancias, la situación geográfica de nuestro país, pues resulta sumamente interesante en el área de nutrición, en el área de fonoaudiología, de psicología, de seguimiento a los pacientes, de trabajo social. Así acortamos el peregrinaje de las familias, reducimos eh, el costo que requiere movilizarse de ciudad a ciudad, de lugares inaccesibles además, pero considero que sí es un trabajo que tiene que ser, que tiene que haber una red importante, así como esta red de conocimiento, de formación, pero una red de atención integral donde todas deben participar. Es difícil establecer estos sistemas, tiene que haber instituciones serias, legalmente establecidas, comprometidas, que además muestren resultados, ¿no? Resultados a largo plazo, no a corto plazo, sino ya pacientes jóvenes, pacientes adultos que han recibido un procedimiento y que este procedimiento funciona. Entonces, ellos al ver los resultados apuestan a este resultado. Es una temática, la fisura, las flaps, que genera mucho movimiento, mucha sensibilidad. Entonces hay que saberlo cómo conducir esto para realmente encaminar una rehabilitación de calidad. Bueno, esta es mi opinión. Gracias. Buen día.
Muchas gracias, Julieta. Thank you, Julieta, for your opinion. It's really interesting, I think. I hope you all could see the translation.
Dr.
Um,
Marina. Dr. Marina,
Yes.
we have about 13 minutes to go over the slide, next questions, and then maybe we can have move to questions and then move to the round
Okay,
table.
so I will give the word to Savita and then we move to the next question. Thank you very much, Suraj.
Thank you, Marina. I just wanted to add into the discussion that was taken along by Dr. Fernando. I think when we're talking of community-based intervention that we're referring to, before we try to commence anything, it's very important that we do a needs assessment at the level of the community. So one is trying to understand what is actually required at the community. And that could also look at trying to identify what are the resources that are already existing in the community. It could be anything. It could be an established government network. It could be some other NGOs or some other systems that are already in place. And if we try to integrate these two, then I think the sustainability of the programs that we commence would be much better.
Thank you very much. Thank you. So we can move to the Danica, can you put the question, please, on screen so everybody can see it? Thank you very much. So these are the official questions we established for this roundtable, but I think the discussion we had before is really very enriching for everyone. So thank you very much. So now we go to the questions. So what are your questions of clarification about the recommendations? Have you some specific question about some of the recommendations we gave? We have the 5 recommendations. If you don't have them in mind, I can remind them to you. And if not, if someone want to give their opinion. I will read the recommendations so you have them clear again. The first one was to integrate cleft care into existing community health programs. The second was establish comprehensive financial and logistical support for the program. The third one was implement hybrid care models. The fourth was develop and implement comprehensive caregiver training and support programs. And the last one was to establish monitoring and evaluation indicators. So is there some question about those topics?
Can I make a comment?
Yes,
This is Ann
please.
Kummer. So first of all, Suraj, that was a great presentation. Thank you very much. I totally agree with Savitha that we need to evaluate what each community needs. But I think overall, what we need to do is maximize technology. And of course, telehealth is an important part of what can be done to increase access, but I think it needs to be almost a stepwise approach. So to begin with, telehealth can be used to provide direct services. And we've found with speech pathology in particular, it's really easy to provide services through telehealth. It's effective, it's cheap, it's convenient. So direct services. But even more than that, I think that we need to use technology to train people in the local areas. And that can be online courses. It can be ebooks, things that are cheap and accessible no matter where you live. So, training those people, because we want to make sure that they are self-sufficient, not just relying on telehealth services from some other place. And then the next thing I think is important is to have a system where we can use telehealth to coach and to mentor the local healthcare providers. So sometimes I will actually do that where somebody has difficulty with a patient and I see the patient with the other provider through telehealth and we can work together and that person can learn through that interaction. So, I think it's a lot of different things, but using technology, typically that's cheap and it increases the accessibility. And so we need to maximize that. But we need to have an infrastructure for that, for people who are on one end providing services to the local healthcare providers.
Yes, thank you. And you are right. I think, and that was one of our discussion points in our prior meetings, and it was we have to educate everybody. So educate the professionals, educate the caregivers, the patients, and also all the professionals that can give support on long distance. So thank you very much for your comment.
Really, what it is, developing a telehealth program that covers everything, not just training the trainer or training the provider, but training the family as well, as you said.
Thank you very much.
Professor Rupa?
Sorry?
Oh, Professor Rupa has raised her hand. Can you unmute, Professor Rupa?
Okay, thank you. Yeah, can you hear me now? Yes,
Yes,
Rupa. Yeah. Thanks a lot for this fantastic presentation and the very, very interesting discussion. Having been involved in a community project for quite some time, one of the pieces that we haven't worked on sufficiently, but I think we should, is to really be able, for sustenance and financial stability, is to be able to identify, document, encourage, and include, what the community generates to us in terms of time or space or resources. They may not contribute financially directly, but making whoever at the community, a unit as a family or a organization or the government, include that in your, financial planning, you will understand that there's a lot of help that's coming from the community, and that makes them, I think, more empowered to contribute more and use shared resources. Sometimes it's not easy in communities to set up independent resources for cleft because in a large community there may just be few kids, but to be able to find that common resources and to give credit to that local community help makes a difference. And today's day and age, with continued financial support can come into question wherever, whenever. It's important for us to strengthen each group locally, even at the hospital level or at the community. I think we have to keep looking that if we want comprehensive care going forward over the years. Thanks, Rupa. That's a very interesting point. Thank you very much. Someone else? Or should we move to the Felicity, please?
Just a question if people had any reactions to what we found in the survey about the adoption of telemedicine. So a third used it, a third didn't, and a third said sometimes. So does that seem surprising or not surprising to you? Did you see any changes? Someone commented in the chat about it being used during COVID, but less now. So I wonder if you're surprised by those findings and want to disagree or have ideas what the barriers might be.
Well, if no one has a comment, I can say that probably there are some legal reasons. And I think there are many places they're still trying to find out how to do it properly without going into any risky situation. I think that's one of the points, because during COVID, we just went straight forward, but then we have to work in some limits or have some guidance to do it properly. And I think that's probably one of the points that's missing, at least from my point of view. Dr. Fernando, please.
Yes, I think one of the reasons why some would say they've used it at some point but did not proceed, because like what Anne said, there has to be the infrastructure for it. For instance, internet signals, the devices, all right? So and we all agree that technology really played a very big part during COVID in terms of extending services. But then again, if the infrastructure is not present, it will be very difficult for anybody who wants to go through that phase to proceed. But yeah, that's where probably government assistance or social civic support can help out in terms of creating and sustaining the infrastructure for telehealth.
Thank you. Savita, please.
Yeah, that's exactly what I wanted to add in too. So I think it's got to do predominantly with the penetration of the internet and the availability of the bandwidth, especially in the case of speech. When we talk of it, we really need a good bandwidth in order to be able to make a video call. It's not enough if I just get a good audio. We need a video call. And so the availability of the device at the patient's end is another thing that has made a difference. So there are many centers I know where, despite telehealth or tele-speech therapy options being available, it is probably successfully delivered only to a small percentage of the population, depending on where they are available and what is the infrastructure availability at that end.
Mm-hmm. Thank you very much. So we will move to another question.
So sorry, Marina. Actually, we're just going to, just Danica here speaking in case you can't
yes.
See. But yes, we'll just be heading over to the summary now, just so we can wrap things up to ensure that everyone still has a break between sessions, because there's lots of great content for everyone shortly. So I will just be sharing my screen again. And Dr. David, if you may guide us through some of the summary and future thinking. Oh, Dr. David, you're on mute.
Sorry. Thanks very much, Danica, and thanks everybody for those great comments. It was interesting the way that a lot of the comments recur, and that they are things that came up, throughout our discussions, and it's good to see that everybody is thinking in the same way. What I wanted to do was just quickly go through and summarize. Now, I think there's one slide you might have missed there, Danica, the recommendations overview. Yep, thanks. So just to overview of those recommendations, the first thing, and it came up, resoundingly, was the importance of engaging all stakeholders and developing and implementing of the process that needs to be done in a collaborative and very open way, and the whole of the team and the patient group and the parents group and the funders need to be involved. You've got to understand, we feel, the existing, what is there at present and how we can work with that rather than trying to make a new system. We need to identify potential collaborators to support the program. And so that is the hospital human resources and the provincial administrators and the NGOs and other organizations. You've also got to identify the support services which can be offered in the community. Now, not everything is suitable for community-based care. And for example, none of us would think that VPI surgery or even cleft palate surgery should be done in the periphery, but we do feel that some of the pre-op and the post-operative care could be done in the local community. The last of the recommendations is that you've got to prepare, and this is the thing that I think is difficult. It's the coordination, getting everybody together, having a serious discussion about how you're going to do it and how to set it up. But then what are your outcome measures that you're going to use? How are you going to evaluate the program? And then how are you going to set up a process of constant evaluation and quality improvement with the data that you get from that assessment? They're the things that we thought were important. And if I could have the next slide, please. There are lots and lots. The mind boggles with the opportunities for research in this area, and I really do think it is a vital area. And the longer you're involved in cleft care and you talk to the families that you've looked after since they were babies, you realize how big a burden the care of these patients is, both to the patients and the families. And I think it is something that we all need to work on to improve. For the areas that we thought could be valuable for research is developing models for interdisciplinary collaboration, and that's very difficult, and also with the community leaders and policymakers. How do you analyze the cost effectiveness of different intervention models? Because some of the things that we're talking about will cost money, but some of the things will also save money. So there may be an overall, it might equalize. So you might save money in your transportation budget, but you might need to increase money in your telehealth budget or funding services in the periphery. Also investigating the long-term sustainability of these interventions. One of the issues with any project like this, you will have people working and then they will leave and new people will need to be trained, and they're maintaining that continuity of staffing and experience. And the final thing that I want to mention is conducting longitudinal studies to affect the long-term impact of these interventions on the health outcomes. And we need to be sure that, as I said before, that we're not reducing the burden of care by just cutting out important services. We need to be able to provide the services that are required to get the good outcomes that we all want, but reduce the burden of care to the patient. So that's my very quick summary, because I know we're running short on time. Danica, do we go straight now to the next meeting?
No, we do have a couple more minutes just to say some quick thank yous. A very, very big thank you to both of our co-chairs, Dr. David and Professor Suraj, for all of their hard work throughout this process and their very thoughtful insights. And also a very big thank you to our SG1 members. Without everyone's participation and engagement, this wouldn't have become what it was. So hopefully everyone found an insightful takeaway from our roundtable. But we're not done yet. There are 2 more meetings that you can join shortly. As we promised, there will still be a 10-minute break between, so you can grab a refreshment, coffee, tea, and hopefully we'll see you in one of the following 2 sessions. If anyone has any questions or any curiosities about navigating to those other sessions, feel free to stick around. I will be here and can help you join that and navigate Circle if there are any inquiries there. Thank you very much, everyone, and thank you all for your participation in the roundtable. That was wonderful.